with this year's theme of the World Health Day that is been observed a few days back by IPH also, and which themed on the My Health, My Right. So with this note, I want to highlight the, the speakers who are already present here, along with our national president of IPHA headquarters, Dr. Sanghamitra Ghosh, and Secretary General of IPHA, Dr. Kaushik Mitra, both are present. So we shall be having our sessions, global and Indian scenario of malaria, to be depicted by Dr. Harsh Rajbangshi. He is the advisor of Foundation for Disease Elimination and Control of India. Then our very respected, very own Professor Dr. Pankaja Raghav, the head of the Department of Community Medicine and Family Medicine from AIMS Jodhpur. She will be speaking on battling the bite, strategies for malaria elimination. And then one of the very dynamic and vibrant public health expert, as well as AI expert, I may say, the smarter solution for a warmer world and leveraging AI and big data for precision strategies in combating malaria, will be speaking by Dr. Kaushik Sarkar. He is the director, Institute of Health Modeling and Climate Solutions and Special Advisor, Forecasting Healthy Futures, Malaria No More. And this whole session will be coordinated by none other than Dr. Pritam Roy. He is the managing editor of Indian Journal of Public Health, along with he is the state coordinator of WHO NTD, neglected tropical diseases. So with this note, I request for the inaugural address or the welcome address towards our president, Dr. Sanghamitra Ghosh, followed by our Secretary General, Dr. Kaushik Mitra. Madam, please.
Good evening, everybody. Am I audible?
Yes, madam.
Okay, welcome to World Malaria Day, though the day was yesterday, and somehow we have to observe today. And the theme for this year is accelerating the fight against malaria for a more equitable world. So the fight against malaria, the malaria is a very old disease for India and especially for Bengal. So in fact, in colonial Bengal, the West Bengal, the Bengal actually was almost depopulated in some of the areas, and it became epidemic from endemic after this colonial movement in colonial era, when the railway lines were made and people moved as coolie and laborer from one place to another. And also it was that time, and especially our decision. So these are the things. It's a historical.
Ma'am, you are not audible. The voice is breaking.
And this malaria parasite in PG hospital now. PG voice is breaking. Can you hear me? Can you hear me? Hello.
Yes, now we
can you hear me?
Yes, yes.
Can you hear me?
Yes, yes.
Okay. So I was saying that this history of malaria little bit, because malaria was very much endemic, and after that it was epidemic in Bengal in colonial era. In India, it was also endemic in Mysore region, and many of the East India Company soldiers, they died from malaria, and many young British soldiers. And that time in army, it started with gin tonic. The tonic was served. It was a quinine mixed liquid. And for the movement of the laborer and the for making of the railway track and all those things for in the colonial era, that time malaria was very much prevalent. It was almost depopulated Bengal's few area, and the malaria parasite has been discovered here in SSKM hospital, that was that time PG hospital, presidency hospitals, by Sir Ronald Ross. And one of the one of his assistant was one Bengali doctor who is not well known in other area, and he was not given any chance in Nobel Prize. Dr. Mohan Bandyopadhyay, gold medal from King Edward. So that was only one award he got, and most of the time we don't know. Even in PG hospital website, his name is not mentioned. So we have uh, the problem of malaria still now, and there is drug resistant malaria. So our uh, eminent speakers who are here, they will discuss all about malaria, and I welcome all our speaker and welcome our moderator, Dr. Pritam Roy, Managing Editor and WHO official. So please, uh, we are going to have a good session for next 1 hour. Thank you.
Thank you, madam, for your inspiring words. I now request our Secretary General, Dr. Kaushik Mitra, to address the audience.
Am I audible?
Yes.
Okay. Thank you, Dr. Anirban. Respected President, Madam, our honorable speakers, resource persons, and all my dear esteemed members from different parts of the country. Yesterday was World Malaria Day, but we are observing the day today. It is an occasion to highlight the need for continued investment and sustained political commitment for malaria prevention and control. So long back in 2007, it was instituted by WHO member states during the World Health Assembly. And as because we can see that in 2022, there was an estimated around 250 million malaria cases, and there are around 6 lakh deaths all over the world due to malaria. And the region that carries the most of this burden was none other than Africa, and it shared a huge part of the global burden of malaria. Now, in recent years, there is a progress in reducing malaria, but it has somewhat come to a standstill, not much in the recent years. So not only does the malaria continue to endanger the health and costing our lives, it also perpetuates a vicious cycle, and that is a cycle of inequity. People living in most of these vulnerable situations, they include the infants, the children, the pregnant women, the children under 5 years, the migrant workers, the refugees, and there are so many indigenous people, the displaced people. So they are getting disproportionately impacted by this disease of malaria. And this year's theme of World Malaria Day is accelerating the fight against malaria for a more equitable world. And this theme is also synchronized with this year's World Health Day theme. The World Health Day theme was My Health, My Right. And it emphasizes the urgent need to address the inequities that persist in to access the malaria prevention, detection, and as well as the treatment services which are available to the people. So prompt diagnosis and treatment, it's very crucial to avoid serious complications or even deaths from malaria. And everyone, I believe, has the right to quality, timely, and affordable services to prevent, detect, and treat malaria. But this is not the reality in true sense. infants and young children still suffer the greatest mortality due to malaria. Pregnancy reduces a woman's immunity towards malaria, making her more susceptible to infection and increasing her risk to severe disease and as well as death. Same for the migrant workers, the refugees, the displaced people. So they are disproportionately affected by this malaria and these conditions. So on World Malaria Day, I appeal to the members of our Indian Public Health Association, let us accelerate the fight against malaria for a more equitable world through ending discrimination and stigma, engaging communities in health decision making, bringing healthcare close to people live and work through primary health care, addressing the factors that increase the malarial risk, including the malaria control interventions in the universal health coverage. So in the next 1 or 1.5 hours, we will be listening to our esteemed speakers. They include Dr. Harsh Rajbongshi, who is over here. He is the advisor Foundation for Disease Elimination and Control in India. He is with us today, as well as we have Dr. Pankaja Raghava Madam, who is also associated with our Indian Journal of Public Health, and she is the head of the Department of Community and Family Medicine in AIIMS Jodhpur. We have with us our young dynamic Dr. Kaushik Sarkar with us. He is very much interested in artificial intelligence, and he will be speaking of the role of AI in malaria. To coordinate this session, we have Dr. Pritam Roy with us. He is the NTD coordinator of WHO and the managing editor of Indian Journal of Public Health. And we have so many members with us today here in the Zoom as well as in the YouTube. You are in the last session. You all are welcome to discuss anything about malaria, what you think so, what you are free to discuss. We have with us our Dr. Ara Devara Rambabu, who is also working in malaria in his state of Telangana. His state in Telangana. We have with us Dr. Prasad Wanginkar here. We can see there are so many I can see in the Zoom. Please, all are free to discuss regarding malaria at the end. So with these few words, I would like to ask Anirban to start the session. We are all eagerly waiting for it, from hearing from our resource persons. Thank you all. Long live IPHA.
Thank you so much to our Secretary General for such illustrious words for us. Now I request Dr. Pritam Roy to start the sessions to give a brief introduction of the speakers and have the discussions carry forward. Thank you. Please unmute, sir. Please unmute. No, not yet. You are not audible.
So it's an honor for us being a member of IPHA that like in all public health programs from IPHA, we are holding the important health days, observing and contributing meaningfully in the domain of public health. And today we are here for the observance of World Malaria Day. So World Malaria Day, as we look forward, is been one of the important health day observed by WHO throughout the world, and all the associations and those who are working for the cause of malaria and public health is meaningfully contributing to it. If we go through the last World Health Day themes, starting from 2014, where we have a theme about invest in the future, defeat malaria. So there was a clear-cut indication for the future investment in malaria. In 2016, we had the theme of end malaria for good. And then in 2017, it's malaria prevention. Let's close the gap. So we were there very close to in the beating of malaria, which we discussed also in 2018. And from 2019, there was a shift. So the 2019 themes and 20 were uh, zero malaria starts with me. So from overall approach, there was ownership in which we individually should also contribute. As an association, we should also contribute. This ownership was very much was brought in 2019 and 20. And then in 21, there was a theme of reaching the zero malaria target. And then in 22, there was a innovation to reduce malaria disease burden and save lives. So lots of innovations were brought in, were thought on, were discussed to reduce this malaria disease burden and saving lives. And last year we had that time to deliver zero malaria, invest, innovate, and implement. So we see that innovations were thought of, and then there was an increased demand for investment and also implement of all the strategies that we have. And in this year, we are thinking about accelerating that fight. And moreover, one of the most striking thing that we want to discuss is that how this fight against malaria for a more equitable world. So we should have the reach to everybody. We should have all the innovations ready, and it must go implement to the last mile challenges, and it must give solution to the last mile challenges. So as we have a discussion today, I would request Dr. Harsh, who is with us, to give us an overall like view what is going on in the global scenario, Southeast Asia scenario, Indian scenario, and would also request that to speak about initial priorities at the government level that we have, which would be helpful for the members to discuss on. So over to Dr. Harsh.
స్పీకర్ మ్యూట్ నొక్కి స్పీకర్ వస్తుంది మాట్లాడచ్చు జానవి ఎవరు మనుషులు కనిపించట్లేదు అది హలో
Mr.
అమరపాణి
Harsh, please.
Hi, yeah, can you hear me?
Yeah, please continue.
Yeah, hi. Thank you so much, Dr. Pritam, and thank you so much, Dr. Sanghamitra, Dr. Nirban, Dr. Kaushik Mitra, for your remarks. And very warm welcome to everyone. And hello to my fellow speakers. We have Dr. Pankaja and my longtime colleague and friend, Dr. Kaushik Sarkar. So I understand we are running a bit behind schedule, so I'll jump straight into it. So I do have a few slides here, not to make this.
రెడ్ క్రాస్ ఉండకూడదు చూడండి రెడ్ క్రాస్ లేకుండా మాట్లాడచ్చు
I think there's some disturbance. I'll just wait for a bit. Okay. So not to make this presentation too academic, to keep it light, I will be speaking very briefly on the global and Indian scenario of malaria. So currently, the affiliation I'm using here is the advisor to the Foundation of Disease Elimination and Control of India. I do hold another affiliation, which I have not used here. I also serve as the technical advisor to the Asia Pacific Leaders Malaria Alliance. So without further delay, here's the global malaria situation. So as most of you might be aware, the recent World Malaria Report 2023 was launched in December last year, where there was an uptick in malaria cases to 249 million as compared to 244 million cases in 2021. And the estimated malaria deaths decreased by around 2,000 in 2022 as compared to the previous year. Similar to the trend what we have been seeing over the past several years, the WHO African region continued to carry a disproportionately higher number of global malaria burden. The sub-Saharan Africa region was home to approximately 94% of malaria cases and 95% of deaths all across the world. And when we talk about the Asia Pacific region, this year it accounted for around 2% of global malaria burden. So when we talk about the Asia Pacific region, it sort of cuts through three WHO priority regions. It cuts through the WIPRO, the CRO, and the MRO. So it starts all the way from Afghanistan till Australia. But the reason I mentioned this statistic here is that historically, Asia Pacific contributed to only around 1% of global malaria burden. And this jump was primarily attributed to the malaria outbreaks in Pakistan last year due to climatic disturbances, mostly floods. Having said that, the global elimination goal remains to be 2030. So this was a brief overview on where we are, but what we should be also looking at are a few lessons from malaria-free countries. So we do have some very, very inspiring stories coming out of various parts of the world. We have Algeria, China, which is our neighbor, one of the most populous regions in the world, Timor-Leste, Azerbaijan, and Sri Lanka. Sri Lanka story, I think most of us might be aware of. So here what I've tried to do, I've tried to list out what were the key strategies and key learnings coming out of the malaria-free journey of these countries. For example, Algeria. So what, before I dive into this, what you will see here is nothing rocket science. Nobody, discovered a new element or, had any eureka moment that resulted in malaria elimination. Today, we are talking about vaccines, malaria vaccines in the African region. While they are of great help in that particular geography of the world, but we must remember that countries have achieved elimination using the existing tools and technologies. China used the 137 surveillance strategy, where they used to initiate the treatment on day 1, resolve the infection reservoir on day 3, and complete all the elimination strategies in the focus areas by day 7. All the countries who have achieved elimination laid down a very, very strong focus on accountability frameworks. They relied on effective surveillance, they relied on case management and vector control tools. Again, all these tools and strategies exist in the Global Technical Strategy by WHO, and they do exist in the National Strategic Plan of India as well. When we talk about India, it has the highest population in the region. I'm sorry, this slide belongs to the Asia Pacific, so it's borrowed from there. And it reported 223,000 malaria cases in 2023, which was an increase by 21% from last year. The highest malaria burden is concentrated in Odisha, followed by Jharkhand, Chhattisgarh, West Bengal, and Tripura. The latest National Strategic Plan on Malaria Elimination, 23-27, this plan will guide us to the national elimination goal of 2030. Because in order to be certified malaria-free in 2030, we need to report zero indigenous transmission of malaria cases in the year 2027, then wait for 3 years before being certified. So this latest NSP was launched in January this year, and the salient features of this new NSP include a dedicated tribal malaria action plan, which has been jointly developed by the Ministry of Tribal Affairs and Ministry of Health and Family Welfare. It also features a graded surveillance and response strategies for varying endemicities, means there is no single master formula for all the regions in the country. This time the strategies will be decided based on the endemicity of the region. Data reporting will be done through the integrated health information platform, which was, I think, long overdue. So we focus on near real-time reporting now, and an emphasis on intersectoral collaboration and private sector data reporting. Private sector data reporting, because as of last year, I think you might be very well aware that malaria has been made a notifiable disease throughout the country by different states. So with this private sector data reporting, we hope to see a jump in malaria reporting, and in the long term, it should help us in reaching the elimination goal. So to further tease this out, we should also understand what kind of species exist in India. So it's approximately 62.7% falciparum cases and 37.2 Vivax infections, which is different from various countries around the globe. Some countries are Vivax dominated, whereas some are falciparum dominated. Having said that, there are still 2 states in category 3, which means an avian parasite incidence of more than 1 per 1,000 population, which are Tripura and Mizoram. And approximately 75% of all cases are still concentrated in the tribal areas of India. So if you look at it, it's a very paradoxical statistic that 8% population in the country holds 75% of malaria cases. And that's why in the previous slide, we saw the current and the latest NSP features a tribal malaria action plan, because these tribal areas are practically the heartlands of malaria. In another step by the government of India, they have identified 27 high priority districts. But as of the information yesterday that was unveiled at the World Malaria Day event in the national program, these 27 high priority districts have been increased to 33 districts. So special activities will be undertaken in these 33 districts with the national program, the Ministry of Health will have a close eye on the progress of these hot pockets. So this till now what I've shown you is where we are, where we have come from. So it's interesting to see where we are headed. So this was a study that was published this year on forecasting malaria elimination in India, where the authors used two ARIMA model and Holt's linear additive models to see where will we end up, whether we'll reach the 2030 elimination goal or we'll fall short of it. Fortunately, the study showed that by 2028, we should reach the national malaria elimination goal if, assuming that there are no outbreaks, there is no climate change emergencies. Since this is a statistical modeling, so there were assumptions taken place. But if we keep on, at the same accelerator pedal that we are, we should achieve elimination by 2028. The success will mostly depend on adopting best practices. So in the first few slides, I had shown you the best practices by various countries, but that does not mean that India does not have its own set of best practices. India has hosted 3 groundbreaking projects, which have emerged as islands of excellence in the country. The first one is the Malaria Elimination Demonstration Project in Mandla. It was a public-private partnership between the ICMR, FDEC India, and State Government of Madhya Pradesh. I was fortunate to be a part of this project, where we attempted to eliminate malaria from the Mandla district, and we were able to do that within 4 years. The next one is the Malaria Mukt Bastar Abhiyan in Chhattisgarh, which was focused on the high transmission pockets in the tribal state. And the third one was malaria elimination in inaccessible areas, also known as the Daman project in Odisha, which was headed by Dr. Madan Pradhan. So these projects have really good learnings. A lot of literature has been published on them. So I would encourage you to look these up online. There are several peer-reviewed literature available on these. So if you want, you can go through them. If you have any questions, please feel free to reach out, because these are the outstanding practices that should lead us to the national elimination goal. So to summarize, I would just like to say that we have the tools, we have the strategies. What we need is the operational excellence and accountability frameworks in the national and state programs. We need to eliminate malaria on a war footing, else we might lose the target. That's all. Thank you so much. Over to you, Dr. Pritam.
Yeah, thank you, Dr. Harsh. I think as one of the person has already posted in the chat also, like we have the strategies, but still why we still have malaria. What I would like to say is that we have the strategies, and that's why there has been a dramatic reduction in the number of cases. So the number of deaths due to malaria has reduced, though there are deaths now, but still, if we look historically, there has been a significant decline, and also in the number of cases. There are pockets, there are areas where still we are having malaria, and I think what Dr. Harsh described as the best practices are the elements to learn how to implement those things. So we don't need anything extraordinary to do, but the things that we need to do is all those things needs to be in place and to be implemented. And we also need to report them truly and mitigate the outbreak. So thank you, Dr. Harsh, for giving us not only the global scenario, the best practices of different countries, but also within the country. I think that is a good as a starting discussion point. So, what you mentioned is that we have to implement strategies, and that's why I like to have our next speaker, Dr. Pankaja, to discuss about the strategies for malaria elimination, and if we can spell out like which strategies worked out best for India. So, over to you, ma'am, for your perspective and delivery. If you can bring it to the full screen mode, ma'am, and then please continue. Yeah, thank you.
Sorry, I was muted actually. So, good evening, everyone. And thank you for inviting me for this important webinar on World Malaria Day. So, I will be talking on battling the bite, strategies for malaria elimination. So I will not repeat this slide. Global burden is already told by previous speaker, but there are certain good news and there are certain challenges. So 43 countries and one territory is certified as malaria free by WHO. And if you want to check which year, which country is certified, you can see very nicely depicted in this particular picture. And very important is Sri Lanka is also certified in 2016. But global burden is still very high. And as far as India is considered, 66% of the cases in our region, Southeast Asian region. And India and Indonesia together, they contribute 94% of the death. This is really a big figure. And there are definitely certain challenges. So this is another achievement. We have 2 vaccines declared, and they are doing great. And there are a lot of research going on various aspects, because a lot of challenges in terms of drug resistance, insecticidal resistance, and other aspects related to malaria. I will be talking on all those things. So so there are new developments which are really required. So countries R&D or global R&D should work very fast. A lot of changes or resistance in different areas are seen in relation to this particular mosquito. So new insecticidal nets are recommended by WHO. The first one is pyrethroid chlorophenapyl net, and it is effective in killing the mosquito. And the other net is also interesting. The combination is with again pyrethroid, pyriproxyfen, and it disrupts the growth of the mosquito and its reproduction. So these are important achievements again, as far as research is considered. And when we talk about challenges, so not in India, but other countries, they are reporting this Plasmodium novel-C, and it has a zoonotic trend. But there are certain reports from Andaman and Nicobar. Again, in-depth studies are required, and they are coming. The samples are coming positive. 53 out of 445 samples for this Plasmodium. Apart from that, there are several other challenges. First important challenge is keeping that fund at very high level. Always, it's very, very challenging. So, tight fund creates a problem, and that is another setback. Maybe there was one question in the chat box. So these challenges will help us in answering that question. And then there is malaria in border areas. migrant population. This keeps on happening, and a more important reason is climate changes. And because of climate change, again, there will be population migration, demography changes, and vector behavior also changes. We were working on this climate change and prediction model we wanted to develop. So soon we will be coming with that. And when we looked at past data, it clearly indicates rising trend in vector-borne diseases, including malaria, when it comes to climate change. So I won't be going into details of climate change, but it's a problem. Another very, very important problem is anti-malarial drug resistance, and that too, Plasmodium falciparum is showing that resistance. So a lot of work definitely is required in these areas. This is another biological threat to malaria intervention. It is observed that there is deletion of this PF-HRP2 and PH-HRP3, and that is creating a problem in the diagnosis. And it is seen in 80% in different areas. So when we looked at globally about insecticidal resistance, so this different color code talks about what is the level of insecticidal resistance. So when we talk about our country, there is resistance for 4 insecticide classes, and that is where continuous research is required. And we need to identify new insecticides, new drugs, and we should keep on working in this area. So coming back to our country, there is this study, and there are several studies like that. I will be sharing some experiences at our place also, as service delivery in context to malaria and other vector-borne diseases. And another experience is about our research carried out on behavior of people in context to malaria control and prevention. So as it is very clearly seen that people definitely don't accept this insecticidal spray. This we have experienced in our campus also. Highly qualified doctors, they also feel that why regular insecticidal spray is required, and they deny and they don't accept it. So this is a study from Northeast region, and you can see they have several reasons for not accepting insecticidal spray. They talk about the smell. They talk about hazards to their children. They feel that it will spoil their walls. So a lot of things, and threat to their important occupation of silk moth cultivation. So coming back to now local practices, this was which we observed this practice is seen in Jodhpur itself, and they have these tanks uh, for fishes, and the same is being used for irrigation. So it is solving dual purpose. So like anti-larval measures, as well as the same water is being used for irrigation. So it's definitely a good practice, and we are encouraging people to utilize this practice in the same area, because we have a lot of other problems in the desert belt. So such news, they keep coming on regular basis because of water scarcity. Uh, there are problems, and maybe they cannot have healthy practices as far as vector-borne diseases are considered. And because it's a dry season, dry area, hot season, so they keep water for animals, birds. That also acts as breeding places. And then because of scarcity, they have to carry water, store water for many days, and again that acts as a breeding place in domestic places. So these kind of news, they are repeatedly coming in the newspaper in different seasons, pre-monsoon, hot season also, and during monsoon season as well. So then we thought we should work in this particular area. This is our field practice area, one of the field practice area. And we identified water bodies, and we carried out a survey, and we found that Anopheles larva was definitely present there. But community were not able to identify that larva. They were not knowledgeable about the larva. So extensive work was carried out at different levels, health sector level, in the health facility, in community, and among frontline workers. And we have seen several challenges, like data management was not done. And once this elimination by 27 was declared, doctors also, including frontline workers, they thought it is not required to report malaria case. It is not required to indent malaria drugs, and all the activities were stopped. And then we got a lot of malaria cases, including falciparum. Vector control measures are not carried out regularly. Biological measures, although they are having huge tanks for Gambusia fishes, but they are not being used. And almost everyone, more than 90% of the households, they do not practice any method of mosquito control measure. And the frontline workers, they don't use Temifos as anti-larval measure because they feel that malaria is no longer a problem in this belt. So we started actively doing work, and we initially targeted ASHAs and other field staff, and we trained them in different aspects in screening, taking blood smear, active surveillance during a particular period when we started getting fever cases in OPD. And we also taught them how to use Temifos, how the dilution is to be done, what is the frequency of application, and then they started practicing it. We also started having awareness program in the schools, and children were actively participating, and we involved them in identifying the larva, and then we requested them to train their parents as well at home. So other groups which we identified was self-help group, and they actively participated in the activities. You can see how they were observing presence of larva in coolers. So not only that, because the labs, they stopped all the diagnostic measure. So medical officer is sitting over here. So our people, residents, junior residents, senior residents, they started training the lab technician, his lab technician, and their medical officer is also there sitting with the group. So the active work was carried out, identifying the larva and using anti-larva measures. And as you can see here, all the community members, not only frontline health workers, other people, panchayat, sarpanch, they were also involved. And then this is the pond, and our people, they taught them. These are the people, including local people. So we had community empowerment, and Sarpanch is also part of this group. And then that gambusia fish were put in the pond, and all of them were so happy to be part of this activity, and they felt empowered. And this activity is now going on continuously with the help of community leaders, community, I mean the school children and other population in the community, including self-help groups. So there are a lot of challenges when we start working in this area. So people do not feel that there is any risk of malaria or any other vector-borne diseases. Slow pace of work. The staff also, they do not understand the importance of larvicidal measures or identification of larva. So a lot of stakeholder meetings happened, and chief medical health officer also started interacting with us. School principals, they were also happy to be part of this activity, and then we also got support from our microbiology department for diagnostics. So last 2 years we were working in this particular research. This is Malaria Elimination Research Alliance nationwide research carried out. It was a multi-centric study. It is completed in February this year. And my colleagues from different institutes, they were principal investigators for their own sites. And it was on community behavior and determinants in relation to malaria prevention and control. And later on, because the results were quite encouraging to carry out further research, so intervention part was also added. As you can see, these are a few findings of the quantitative part. This was mixed method study, and as you can see, the overhead tank, this study was carried out in urban and rural area. Bikaner was the rural area, and Jodhpur was urban site for this particular project. So mostly overhead tanks remain uncovered or partially covered. Drainage facilities, open drainage facilities are there in urban as well as in rural population. Almost 50% of the rural, they have open drainage. They do not have closed drainage facility. As far as waste disposal is considered, there is no support at all as far as waste disposal is considered in rural area, but around 50% of the urban population, they inform that municipal corporation people, they come and collect the waste material. As far as protective equipments or protective methods used by the community, urban population, 10% of the population are not using anything. Whereas rural, it is 45% of rural population, they do not use any protective measures. When we ask them about insecticidal impregnated nets, mosquito nets, about availability, only 18% urban population, they have it, and 8% rural population, they are supplied with these nets. When the question on use was asked, both the urban as well as rural population, they do not use it. And when they were asked what is the reason, they actually do not have any specific reason why they don't use. Around 75 to 90% of the population, they do not have any specific reason. But rest of the population, like they said, suffocation, some of them said discomfort, some of them said that they do not have money to purchase. So these were certain reasons why they do not use mosquito nets. When they were asked about accessibility of health services, it is a really shocking figure. 40% of the urban population, they inform that traditional healers are closer than other public health services or any private clinics. And more than 50% of the rural population, PSC is a little closer. So closer means less than 5 kilometers distance. So it is really a strange number. And 20% of the population did not receive any educational message as far as prevention and control of malaria is considered in last 6 months. And when they were asked if they have fever, whom they contact, and one of the options was ASHAs and healthcare workers, 60 to 70% of the people in both the places, urban as well as rural area, they said that they do not prefer ASHAs or any healthcare worker. So this is qualitative aspect of the study. And as you can see, similar picture is seen. There is no training of ASHAs, ANM, no surveys carried out. Skilled manpower is absent, and that is absent, and that of the important strategy now globally recommended for malaria elimination. So at district level also, they are least bothered. IC material is supplied by the state, but it is just kept at the district level and not supplied to sub-center or PSC level. So there are a lot of problems at different levels. So after identifying the gaps, we targeted IC material, and then whatever IC material was there, we evaluated the IC material. And as you can see, low level of literacy is there in the population. So considering low level of literacy, the IC material supplied was actually not understood by the people. And that is why we felt that, or the quality of IC material was quite poor. They did not understand why the tires are kept in the picture, why those earthen pots are there. There was no clarity in the picture and it was not understood by them. So this is one of the pamphlets circulated, and you can see a lot of material, and considering the literacy of the population, it is of no use. So we modified these IC materials, and then we recirculated the IC material after stakeholders meeting. And you can see our research team is educating the people on malaria and different aspects related to prevention and control. So this is again different IC material. You can see lot of things, lot of words are there.
Dr. Pankaja?
Yes, I'll complete 2-3 more slides. So this is modified version of the IC material. So now the people are started using that. And not only that, this is stakeholders meeting to educate them. We involve children in these activities, and you can see the participation of children. So this was drawing competition held, and they participated. Essay competition, and not only that, you can see wall paintings, and these are the rallies, how people are actively participating. And these are the wall paintings, and children were actively doing this, happily doing, and they were so empowered. And I think such kind of activities should be carried out across, and people will be educated. Thank you.
Thank you, ma'am. I think it's a very good long discussion about not only the strategies that we have at the national level, but then how we can implement those strategies at the local level and what are the challenges. So I think as a public health expert, these are the things that we need to do, find out the reasons and implement things at a local context, find out the local reasons so that it can be best implemented. So thank you, madam, for bringing up the strategies and also the experiences from the field. So these are really helpful for the discussion. Now we'd like to continue with our next level of discussion. So we had the overall idea, we have the uh, strategies in, and what are the challenges. But then what is the next future? And today everyone is talking about AI. So I think how can malaria be behind from AI? So for this, I would request Dr. Kaushik to speak about and have a good discussion. I think all the audience will like this. Something new, something interesting. Over to you, Dr. Kaushik.
Thank you, Dr. Roy. Good evening, Dr. Ghosh, Dr. Mitra, the IPHA leadership, Dr. Dalui, and my co-speakers, Professor Raghav and Harsh. So I'll share my slide in a bit, and we'll make it a full screen. So as I start talking about the usage of artificial intelligence, my name is Dr. Kaushik Sarkar. I'm the director of the Institute for Health Modeling and Climate Solutions. And IMAX is a global center of excellence under Malaria No More's Forecasting Healthy Futures initiative, which was launched with support from the Reaching the Last Mile. And we have been grateful for a continued support from the RLN as well. What we do at IMAX is basically try to understand the root of the problems, which start with the climate-sensitive diseases, and try to transform global health with innovative climate-smart solutions. And I'll come in a bit what climate-smart solutions are. So before getting into the nuances of malaria and data and AI and other things, I'd like to remind ourselves that climate change is affecting more than half of the infectious diseases globally. And those of you who have read the Nature publication from Mora and colleagues in 2022 are aware of this figure, which kind of showcased that more than 1,000 pathways exist between the linkages of different climate parameters and infectious diseases. And among those linkages and among those changes and the aggravating pathways, vector-borne and waterborne diseases kind of top the list. And malaria is, of course, at the forefront of those challenges. Philippi at Wellcome did a fantastic estimation I think in 2021 or 2022, where he and his colleagues showcased that about 3.6 billion additional people will be at risk of malaria by 2071. And many of us might think that, that's a distant nightmare. We won't live for another 4 decades. So why do we care? Maybe our children will take care of those challenges. But, we are seeing, as Harsh was stating, that flooded Pakistan witnessed in 2022 5 times increase in cases from just 500,000 in 2021 to 2.5 million cases in 2022. And at the same time, there are several countries like Sudan, Myanmar, and other countries where there is a combination of climate and conflict shock that is happening, where we are seeing that alongside climate change, the changes in the geopolitical scenarios are actually causing some synergistic effect, producing some synergistic effect on the population movement, migration, and so many other things, which are causing disease outbreaks. For example, I think MSF found in Sudan and other places several fold increase in malaria in the past years. And another important issue that came up with climate change is in African countries where the Asian Anopheles was not that much present. They are establishing, and there are at least 7 African countries where the changes that happened in the past 2 decades can actually reverse. So these are all threats that we are seeing globally. And when we talk about India, Dr. Dhiman and colleagues found out, I think in 2019, that the malaria suitability of several districts will increase. And by 2030s, we'll find more than 10 districts in India where new foci are kind of getting established due to climate change. So those predictions are really concerning. Now, in these challenging circumstances, if we want to tackle the disease elimination scenarios, we need to think from 3 perspectives. First, that we need to handle the speed of transmission, because the changes in temperature, the changes in rainfall patterns, extreme weather events are actually increasing the vectorial capacity, which means the mosquito vectors will be more, will spread more, and will live longer. And then pathogen viability, which means that the parasites will again be more viable in the conditions. So the transmissions, even in the non-endemic regions, may increase. Of course, it will pick more in the endemic regions. There is a shift in disease dynamics because of the ecological chain of changes that we see due to climate change. And that is causing increase in and shifts in the peak transmission seasons. So again, Dr. Dhiman and colleagues, particularly in India, showed that how transmission months are changing in the southwestern India, in the northwestern India, and also in southern India. So none of the regions of India are actually getting spared from these shifts in thresholds and temporal displacements. And the third part is, of course, compromised health systems. Whenever you have outbreaks or extreme weather events, you are going to get these challenges. So the major change that we are seeing is we have to cope up, we have to be more resilient to these dynamic changes. And to address those changes, the thing that we try to achieve here is we call precision programming or precision public health. It has 3 parts, starting with forecasting. So forecasting essentially means predicting the number of cases, as you can see on the screen, and several different applications. So if you can forecast the cases of a disease, you can anticipate its test requirements. How many stockouts will happen for medicines, you can anticipate that. You can also identify what is needed to run smoothly the facility-based and referral care services. The second part of that is early warning. If we can provide early warning for outbreaks, even before outbreaks, the health manpower can be well prepared, the health resources can be well prepared. Think about a scenario that people would have known that COVID-19 would be coming in next 5 years, and what would have taken place? There would have not been a COVID-19 pandemic. So, and the third part is that stratification, where we say that if you can stratify the diseases properly, you can tailor your interventions. You can train your... I request everyone to mute, please. Thank you. Finding the areas where specific interventions are needed and what kind of interventions will work in which areas. And then tailoring the risk communications, also the health education and other measures. And for all of that, we need intelligent systems for forecasting, early warning, and risk stratification. And the pillars that you see here, human-centered design, cutting-edge artificial intelligence architecture, open source language, and immersive visualization, these 4 are the pillars of an intelligent system that can do all of these. Now, to develop an intelligent system that can do these things, you have to overcome the challenges of health information system, climate information system, and so many other information systems that are kind of siloed globally. And for that, the input that is required is, of course, from various different sectors. First is public health, second, meteorology departments, third, geospatial data, fourth is soil and vegetation matrices, fifth is population information. Now, at IMAX, what we have done, or achieved rather, is we aggregated all of these different local and global data sources and put it into a data store and processed that data to make it artificial intelligence ready. The moment it becomes AI ready and it becomes integrated, then is the role of automation. So you might have heard that one model of estimation of malaria or forecasting of malaria or dengue or some other disease is not working in some other models. And I have read numerous research papers where people in the discussion section starts writing that, there this model worked, but in our case, this model works. I think this was decided 100 years back, and this was deliberated on even 100 years back when Hackett and others in epidemiology told that malaria has thousands of micro-epidemiological situations. So if you try to model for a single area, it's not going to work for the other area. So you have to automate the selection of variables, selection of data, modeling, and other stuff. And so to achieve that, before feeding these information to the AI models, we need something that can automate these integrated data set selection processes that we call attention models. And from there, we send the data to forecasting modules that can forecast data. But these charts that you see there, which are kind of forecasting charts, they never help. Because if I present that chart to a health minister or a health secretary or a health policymaker, it would be kind of meaningless for them in their busy schedules. So you have to present the data in a meaningful way to policymakers and public health managers. And there comes the role of operational modeling. So operational modeling essentially means that when you have the forecast, how can you take out or extract meaningful insights from those information and can put those information into or package those information into the form of visualizations and prescriptive actions that help people to take decisions, which is basically the decision support systems. So there are three parts that I talked about: data integration, all of these models, which I call fusion architecture. And then the third piece is, of course, the output part. And globally, hundreds of technologies exist. I will particularly name IBM's The Weather Company and the Tableau Foundation, who helped us right at the beginning with some solutions. We also got help from Cognizant Life Sciences and others in this entire solution-driven approach. And at the same time, the system that we could develop is an open source system that is based on Python. And now when I talked about all of these technologies, what is practically needed? So if health sector goes to the technology sector and asks that what do the health sector needs from the technology sector to make their information systems climate smart? So these are the three things that are needed. First is artificial intelligence and automation. So AI is actually improving the weather data interpolation capabilities, disease pattern recognitions, outbreak predictions, parasite and vector detections, and several other applications are there. Big data systems and cloud systems, in very simple way, they make the data more reliable, more interoperable. And why this is needed, if any of you have seen the climate data and also the health surveillance data, you would understand that it is incredibly difficult to bring together those two data sets if you are accessing granular reanalysis data or weather station data, because the index never matches. So you have to make those interpolations to identify that what type of climatic changes will affect and cause what kind of disease problems. And then there are several other tools like middlewares, blockchains, and IoTs, which are kind of supportive tools to build up the framework, to improvise the framework, to create more data integrity, real-time data acquisition capabilities, and all. But I think the bottom line here is that you need artificial intelligence, you need big data engineering, and you need cloud systems if you are going to move to climate smart data systems. And for that, countries definitely need to leverage those infrastructures. So at IMAX, we have three strategic priorities: digital innovation, knowledge and networking, and technical assistance to countries. I won't get into the details of that. Rather, I'll get into the focus part, that when you have all of these technologies, how can you apply those technologies in a human-centered way? So the first part that we do is we need to create an integrated data store for the climate, health, population, and several other information. The second piece is all of those modeling and broking apps, which provides the foundational architecture of your predictive and forecasting solutions. Third are mobile applications. These are there for a very long time, like in-health applications. There are tons of in-health applications that exist, but what are new in this area is AI microscopy. One AI microscopy application we are developing in collaboration with the Mohammed bin Zayed University of AI. And then there are large language model chatbots like Malaria GPT that has also been developed by the same collaboration of ours and the MBZ UAI. And there are several web applications that are needed to be there. Digital twin systems are VR solutions that can provide virtual reality of the risk predictions that happen in large-scale situation to enable you to visualize what the risks are, which are way ahead of web-based dashboard systems that currently exist. But to achieve all of this, you need to structure these applications to different user actors and stakeholders, and also ensure that there is an engine room in each of the country, and there is an alliance between the different ministries that ensures that data are aggregated, and this engine room kind of provide the necessary technical capacities to the ministries of health, to the other ministries and departments. So this is a work that is done by the health ministries and the private sector in a very collaborative way. In a siloed environment, this can never succeed. And of course, there is a role of community-based services and citizen science approaches within this ecosystem, and that plays a very big role. And you might have seen or read the reports of Global Fund, especially the op-ed of Peter Sands, I think published earlier this year, where he highlighted the successes in some of the places, even where mobile networking services are not available, but health information system can help a lot. The next part within this is some of the tools that we develop. So this is one tool that we developed for Odisha state of India, which kind of highlights the, where the cases exist, where the clusters of infections are, and how these cases change across the board for each of 5,000 population, that means sub-center areas. And then we also provide a lot of prescriptions like, what is exactly required at the last mile? Where do you anticipate the stock out situation? What are the alert? What is the test requirement, treatment requirements? Where do you need to do what activities? For example, LLIN education, bell ringing activities, IRS and others. So Harsh was talking about Daman, and I'll talk about that a little bit, but we kind of provided a necessary digital support to ensure that those services become enough efficient to reduce malaria at the last mile. Alongside that, we had a mobile application that provided strengthening of surveillance at the last mile in, I think, more than 300 fever treatment depots that we established between 2019 to 2021 in our project. These are solutions that we are currently doing in Indonesia, and this is the world's first ever digital twin that we launched from the support of the Reaching the Last Mile Again in collaboration with Mohammed bin Zayed University of AI and Corica. And it was launched in UNFCCC COP28 last year. as the first ever digital twin that highlights in real time the weather situation and the risk of malaria in different areas. So this is the difference between a dashboard and a twin. Here you can see in live situation that what is happening in those areas. Here you see the numbers and cases. Both are fed, but through different AI models. But to build these things, you need a foundational data architecture. So these data stores are really important behind that. This one is the application of computer vision technology, again, developed in MBZ by the scientists of MBZ using computer vision solutions that can detect malaria using the microscopic images. So you can see on screen that if you select the microscopic images, this application can tell you whether this is a falciparum or vivax or other cases. And these spellings may not be familiar to you. They're more tailored to Indonesia because we developed the application for Indonesia. And the other one that you see is basically the first version of Malaria GPT, thanks to MBZ. We reviewed 28,000 open source articles and then combined the insights of all of those articles from 1832 to 2023 and fed that into a Malaria GPT, which provides now information on malaria. This is, I really wanted to highlight this particular aspect, that what happens when you apply these targeted interventions in a particular area. So versus control areas, in intervention areas, in the state of Odisha, when we applied the digital solutions, we found an effect of more than 80% higher decline. So malaria cases were declining all across. But in the areas where we applied the solutions, where we activated the frontline workers and ensured that these decisions are taken care of and implemented the last mile through fever treatment depots, there were more than 80% additional reduction of malaria in that population. So that's what is required when you are dealing with uncertainties and aggravated effects of climate change. As I was saying, that you need interministerial collaborations. In Indonesia, last year, we launched the National Strategic Alliance for Responsive Health Adaptation in collaboration with the Ministry of Health, Ministry of Environment, Forest and Climate Change, and their Meteorology Department, BMKG. In India also, we formed an interagency committee, expert committee on malaria and climate in collaboration with IMD and others. So these interagency multi-sectoral alliances, committees are quintessential when you are moving into this sophisticated level. And I personally believe that, the way India is moving forward with the National Digital Mission, the Startup India mission that exists, ecosystem that exists currently in India, and with a phenomenal kind of interlinkages and co-working culture within and across the ministries, I think India is very well poised to set the trend for next generation strategies for malaria elimination and also for other disease elimination, not just malaria. So it can start with, but it can continue. We do have a global expert network across 25 countries, and we are supporting a few scientists globally. And there are very senior scientists also. Until last year, this was an invitation-only network. This year, we are opening this up for scientists across the globe who are interested in this particular field at the intersection of climate and health, specifically climate change and vector-borne diseases or neglected tropical diseases and others. So if any of you are interested, you can join the expert network by scanning the QR code, or you can reach out to my colleague who is managing this network, Grace Scheme. And one of the tools where we cataloged all of the solutions that exist globally as of date is basically a cataloging of these digital solutions. So in this catalog, we kind of identified all of the digital tools that exist globally. So it's probably having some issues with it. Yeah. So you'll find a report and other things in in this, all the repositories that exist for the digital tools that are there globally. What are the barriers and the challenges? What are the enabling and facilitating and hindering factors and others in this particular research? The tool was developed by 5 scientists of the expert network, and then we implemented this across the globe, across the board, across our network. So with that, thank you for this evening. I know it is impossible to do a justice to this particular complex topic at this point of time, but if you have any questions, feel free to reach out to me over LinkedIn or over email. I'll be happy to answer. Over to you, Dr. Roy, and thank you so much for this invitation.
Thank you, Dr. Kaushik. I think it's very interesting. I think the future, like how we can do research, how we can integrate data, and how we can forecast is very, very important. I think it's a very short, limited time. I think it would have been very good. It would have been a more time to discuss and learn more. But anyways, these are the things that we can do. We definitely have a more detailed discussion on these topics. We'll take a definitely webinar so that we can move to the discussion. So thank you. And I would like to take up if anyone has a few burning questions, like we can take. So anyone, if you have something very pertinent question, you want to ask to our speakers.
Question is in chat box. You can take one question from there, and it's already time is over. So not more than one or two. You can see the chat box.
So there is a question on the vaccine only. So the Dr. Pankaja Raghav madam already answered this. So strategy to integrate the NVDVCP and NPCCCHH. So I think Pritam the Kaushik and madam can answer it. So this is our question. It will be taken. Kaushik, please unmute.
I think NVBDCP and NPC, or rather NCVBDC, which is the National Center for Vector-Borne Disease Control, and NPCCHH are two buildings which are working side by side, and they are closely collaborating. Both are within the NCDC campus. Both are well connected. And I think within the health ministry, as I was saying, these departments are already in sync. Yes, you might see differences in, strategies of how outbreaks are handled or how strategies are handled, and that's because the mandates are different for the divisions or departments. But I don't think there is a silo between the two departments. Rather, they are already integrated.
Madam, any comment on it?
What was the question actually? Because vaccine question was already answered.
No, madam, the strategy to integrate the NBBDCP and NPCCHH. So
okay. So actually they are working together only, but this climate change program is recently started. So most of us maybe they are not aware about this program. So they are working together.
So I think in the climate change perspective, they have a overall domain of lots of diseases and health-related changes and issues related with climate change. And one of them is vector-borne diseases. So there is a synergy among them, and there are in different like intersectoral coordinations are there, and the ministries are working together. And so it's an important part in that way integrated. However, the portals or the program divisions or the program lines remains different. So it's not because they have their own aims and goals and objectives, but however, there is a integration which is important, and I think within coming times, this will be more reflected in terms of documents and in terms of implementation.
So I think we can conclude, and we can have the vote of thanks from the Secretary General also. So any more questions, we can, you can, all those delegates can write us, our eminent speakers or the panelists, they could answer it. So a concluding remark from Dr. Pritam Roy, then the valedictory, then the vote of thanks from the Secretary General.
I think as a public health professionals, we had a very good evening in discussions with important topics, not from routine discussion, but along with the statistics, the strategies, the interventions, and of course the way forward and the future that we have seen. So it's an interesting discussion, and I think on behalf of IPHA, we should continue this type of discussion, deliberation, and we should also work together. And on behalf of our association's journal, Indian Journal of Public Health, we also request our esteemed members to do submit articles, especially on modeling.
Some the unmute your another device, yes.
So it's a pleasure that we have such a wonderful evening having discussion of this public health discussion, and we will definitely keep on continuing this type of deliberation, and IPHA will bring more flavor. And as a member, we should also work in this domain on a greater forum. And on behalf of our esteemed associations, journal IJPH, I would request all the members to do submit their literary work, especially on modeling and those articles or field implementations to our journal, and we'll be happy to publish. So over to our leadership for their views and concluding remarks. Thank you.
Over to Kaushik Mitra, Dr. Kaushik Mitra.
Thank you. We have come to the end of this session. The session was really exciting. We had three speakers from different aspects who spoke about Dr. Harsh Rajbongshi, sir, Dr. Pankaja Raghav, madam, and Dr. Kaushik Sarkar. They have spoken about different aspects of this malaria, and very well moderated by Dr. Pritam Roy and Dr. Anirban. And I would also like to extend my thanks and respect to our President Madam who has supported us, Dr. Sanghamitra Ghosh. And last of all, the audience here, as well as the audience who are listening in the YouTube. So I would like to extend my heartiest thanks for them, and would like to do more such programs in future, as well as some workshops, master classes, CMEs, and this online observation of days as well. Thank you all. Good night.
Thank you. Good night.
Thank you so much. We are closing this session. Thanks to the speakers. Thank you.